A skeleton is a reminder that within every body there is a structure that holds us together. Assalamu alaikum warahmatullahi wabarakatuh. My name is Nur Humaira Aisyah, and today I will be presenting about the skeletal system. These are the topic outline for today. The foot anatomy of the bones. There are three types of bones in the foot, which is the tarsal, the metatarsal, and the phalanges. The tarsal consists of 7 bones, which you can see in the image is the talus, calcaneus, clavicular, the 3 cuneiforms, and cuboid. The metatarsal have 5 bones, and lastly the phalanges have 14 bones, which consist of the distal, middle, and proximal of each toe, except the great toe, which has 2, which is the distal and proximal. Moving on to the anatomy of the muscle. The sole consists of 4 layers. The first layer has the abductor hallucis, the flexor digitorum brevis, and the abductor digiti minimi. The second layer consists of quadratus plantae and lumbricals. The third layer consists of flexor hallucis brevis, the adductor hallucis, and flexor digiti minimi brevis. And lastly, the fourth layer of the sole is plantae interossae and dorsal interossae. Moving on to the dorsum, there are 2 muscles, which is the extensor digitorum brevis and the extensor hallucis brevis. For the innervation of the muscle, in the first layer, the abductor hallucis and the flexor digitum brevis both have medial plantar nerve, while the abductor digiti minimi has lateral plantar nerve. Moving on to the second layer, both of them has lateral plantar nerve, but the lumbricals has an addition of medial plantar nerve for the medial part only. The third layer, for the adductor hallucis and flexor digiti minimi brevis, both of them are lateral plantar nerve, but the difference is that adductor hallucis is the deep branch of it, while the flexor digiti minimi brevis is the superficial branch of it, and the flexor hallucis brevis is the medial plantar nerve. On the fourth layer, both of the muscles have lateral plantar nerve, and in the dorsum layer, both of the muscles are from deep fibular nerve. Then we have the ligaments. There are 3 major ligaments, which is the plantar calcaneo-navicular ligament, the long plantar ligament, and the short plantar ligament, as you can see from the picture. Remember that the ligament is the connection between bone to bone. Then we have 4 major tendons, which is the arteries, the tibialis posterior, tibialis anterior, and lateral malleolus. The tendons are the connection between muscle to bone. So the Achilles is important for the plantar flexion, tibialis posterior is for the inversion, tibialis anterior is for the dorsiflexion, and lastly lateral malleolus is for the eversion. The arches of the foot. There are 2 types, which is the longitudinal and the transverse. The longitudinal consists of the medial arch and the lateral arch. The medial arch is slightly higher than the lateral arch, which is flatter. The medial arch is formed by the calcaneus, talus, navicular, 3 cuneiforms, and the first 3 metatarsal bones, while the lateral arch formed by the calcaneus, the cuboid, and the 4th and 5th metatarsal bone. The transverse arch is located in the coronal plane of the foot. It is formed by the metatarsal bases, the cuboid, and the 3 cuneiform bones. The development of the foot, or known as the morphogenesis of the foot. In the 4th week of embryo, the bud starts to germinate and the size increases, as you can see from the picture, and it springs naturally from the trunk. In picture B, the differentiation is initiated and there are 3 regions that starts to be visible, which is the thigh, leg, and foot. In picture C, which is the 5th week, it will have a rounded foot disc, ventral surface faces the head, and inward rotation occurs. In the 6th week, which is picture D, inward rotation continues and medial surface faces the medial plane. The preaxial is known as the cephalid and the postaxial is the cauda, and interdigital notching is present. Picture E, features of the previous stage are accentuated, and the digital notching is deeper. On the 6th week, which is picture A, the foot structure is more recognizable. And on picture B and C, the 7th week, both feet face each other and the feet are in the praying position. The toes are spread apart and the big toe is on the tibial border of the foot, and the toes are still fanning out. And lastly, in picture D, the 8th week, it is the mark of the end of the embryonic period. So in picture D, the foot is in equine supination and the toes are spread. Some diseases related to the foot is clubfoot. So what is clubfoot? Clubfoot is a condition that involves the foot and ankle in which it turns inward and downward. It is caused by the shortening of Achilles tendon, and it is a congenital condition, which means it is present at birth. An alternative name of it is Talipes equinovarus, which can be found with an ultrasound on the 20th week of pregnancy. Clubfoot etiology. So what is clubfoot? What causes it? So neuromuscular factors may be due to distal arthrogryposis type 1, which is the mutation at two genes, DPM2 and MYBPC1, which limits the movement of the joints before birth, which is only a speculation. It is an autosomal dominant pattern inheritance. It can be due to myomeningocele, which forms the spina bifida. Spina bifida is an abnormal spine growth between the gap in the bones. So the sac contains the spinal fluid, the spinal cord, and the meninges. Due to histological factor, it may be because of abnormal peroneus brevis histology or increase in collagen synthesis, primary germplasm, and cartilage defect. If it's because of genetic factor, it may be inherited as a polygenic multifactorial trait. And environmental factor may be due to cigarette smoke exposure in the utero, seasonal viral infection, or because of early amniocentesis. The exact cause of clubfoot is not fully understood, but it is believed to involve the combination of the genetic and environmental factors. Aggrecan is a protein that plays a crucial role in the development and maintenance of cartilage, including the cartilage in the joints. So the molecular composition is that Aggrecan is a big molecule which consists of 2,397 amino acids. The chains are attached by the keratin sulfate and the chondroitin sulfate, as you can see from the picture. The protein structure is the Aggrecan has 3 globular domains and the chains are attached between the second and third domains. The chains are linked to a long chain called hyaluronan. This linking helps in holding things together in the cartilage. The chains have a lot of negative charges that attract water. The Aggrecan acts like a cushion, so when there's pressure, the water gets squeezed out, and when the pressure is gone, the water comes back, like a sponge bouncing back. The role of Aggrecan in cartilage health is that if Aggrecan and collagen break down, it can lead to osteoarthritis. So when these parts break, these cartilage can bounce back as well, so making these joints less flexible and causing pain. So who cured clubfoot? Dr. Ignacio V. Ponseti was known as the cure of clubfoot. He once said that your child is perfect, we only have to straighten his little feet. Dr. Ignacio has a degree in Bachelor of Science in Biology and Doctor of Medicine degree at the University of Barcelona. He received many awards because of his treatment that was non-surgical. This treatment was known as the Ponseti Treatment. The Ponseti treatment consists of 3 steps. First step is the casting, which can be done as early as 2 to 3 months of age. Correction must not be done by force, as the calcaneus needs to move freely so that the correction happens. The clubfoot is kept in the plastic cast for 5 to 7 days, and it is weekly changed so that the foot can gain proper correction. The second step is the tenotomy. It is performed because the calcaneus still has strong plantar flexion due to the shortening of Achilles tendon. Then we need to reapply the casting, which remains for 3 weeks, but for the old children, it remains for 4 weeks. The tissue will form between the 2 ends of the cut in the Achilles tendon that will reattach. And lastly, the third step is the bracing, which prevents relapse. The children need to wear the foot abduction brace, as you can see from the picture. This treatment is known to be 95% effective, and it is used at least until the children is 4 years old. For the first 3 months, we need to wear it for 23 hours per day, but we can reduce it slowly. The external rotation of the foot should be 60 to 70 degrees. And with that, This marks the end of my presentation today. These are the references I used for the presentation. Thank you for listening.